I'm Bruno Paiva from the University of Navarra in Pamplona, Spain. At ASH, we presented an oral abstract on the kinetics of serological and MRD assessment in patients with relapsed refractory myeloma treated with ide-cel in the phase 2 KarMMa study. And I believe that this data is important because until now, there is very limited data on MRD in the field of CAR T cells in myeloma, and also because the scarce data that was out there was showing some unexpected results of earlier MRD responses when compared to serological responses, and uncertainty about what would be the time point, the ideal time point for assessing depth of response, as well as the clinical significance of deep responses defined either by complete remission or MRD negativity. And this was the reason why we conducted a very large study on MRD assessment using next-generation flow, NGF, as well as next-generation sequencing, NGS, at 4 different time points after ide-cel infusion, month 1, 3, 6, and 12, and compare these MRD results with serological response. First, we showed, again, good correlation between NGF and NGS. Most results were concordant. Only a few discordances that were in fact not related to sensitivity, but with the fact that a fraction of samples is hemodiluted, particularly at month 1, but even throughout the first year after ide-cel infusion. And this may be probably related with the lymphodepleting chemotherapy before ide-cel infusion, and it's something to consider, analyzing hemodilution and the quality of the bone marrow before saying it is MRD negative. This being said, both methods performed very well and identified a subset of patients, unfortunately small subset of patients, with sustained MRD negativity for 1 year and a median progression-free survival that was not yet reached with a median follow-up of 2 years. Then regarding serological and MRD responses, we showed that at the beginning, 1 month after ide-cel infusion, the only depth of response that indicates patients that may do well is MRD, because CR versus no CR showed no prognostic value. And this may be related to the fact of the presence of long immunoglobulin half-lives and the delayed clearance of the M component. By contrast, at month 3 and beyond, we showed that, contrary to the newly diagnosed setting, here in this patient population, both CR and MRD negativity were required to identify patients with longer progression-free survival. And this may be related to the fact that some MRD negative results were indeed a false negative, probably because of extramedullary disease, which frequency is higher in this patient population. Finally, we showed for the first time a potential new role or a new biomarker that will be the measurement of normal BCMA positive plasma cells that can be easily done using NGF, and this could be a surrogate for the loss of CAR T cell persistence and or functionality, and could be particularly useful to discriminate risk among patients with undetectable MRD. Indeed, we showed that at all time points, we saw patients with reappearance of normal plasma cells before the reappearance of MRD, and at all time points, this was prognostically relevant. Almost in all time points, we saw that reappearance of normal again, BCMA positive plasma cells in patients with undetectable MRD, resulted in a median PFS almost identical to that of patients with persistent MRD. By contrast, those patients with undetectable MRD and no reappearance of normal plasma cells, indicating persistence and function of CAR T cells, showed much longer progression-free survival.